To our speakers, we'd like to say thank you for participating today and for your continued support and leadership in One Health. Leading us off today will be Dr. Ed Brycewart. Dr. Brycewart is a veterinary internist and professor at the College of Veterinary Medicine at NC State University. He's also an adjunct professor in infectious disease at Duke University Medical Center and serves as the Chief Scientific Officer at Galaxy Diagnostics. His presentation will be followed by Dr. Bob Mosiani. Dr. Mosiani is a practicing rheumatologist focused on the accurate diagnosis and management of chronic disease. He's the founder and general medical director at the Translational Medicine Group in Rockville, Maryland, and also serves as the chief medical officer at Galaxy Diagnostics. This next slide is an image of the One Health umbrella. One Health action requires a willingness to listen and willingness to work together across species and across disciplines. And in August 2008, an exceptional biomedical collaboration between Dr. Mosiani, a physician, and Dr. Breitschwerdt, a veterinarian, started with the phone call. Between animal health, environmental health, and human health, there should be a unified approach. For example, there is significant comparative medical importance in studying the pathological consequences of naturally occurring persistent vector-borne infections across animal species. And now, without further ado, I'd like to turn the webinar over to Dr. Ed Breitschwerdt. Ed's topic is Bartonellosis, a One Health approach to an emerging infectious disease. Ed, your microphone is live, so please just instruct us when to advance your slides, and please feel free to go ahead and proceed with your presentation when you're ready.
Thank you, Peter. Next slide, please. In the context of disclosure, Peter has pretty much covered these. I am also a consultant for IDEXX Laboratories in Bayer Animal Health, and I am the principal investigator for the Intracellular Pathogens Research Lab, which most importantly has generated the vast majority of the data that will be summarized in my presentation. Next slide. In the context of research funding, particularly as it relates to our work with human Bartonellosis, I would like to acknowledge the American College of Veterinary Internal Medicine Foundation, Bayer Animal Health, IDEXX Laboratories, Galaxy Diagnostics, the Kindly French Foundation, the Sigmund Trust, and private donations from quite a few individuals to the North Carolina State University College of Veterinary Medicine Foundation. Next slide. So we have a pretty ambitious outline for my portion of the presentation. We'll first do a very brief introduction to the genus Bartonella, discuss vectors, reservoirs, and pathogen transmission, then proceed with a very brief overview of disease pathogenesis, which Dr. Mosiani will amplify substantially. Try to help you understand how our research progressed from cats to dogs to dolphins, horses, and ultimately humans, and then emphasize the One Health importance of a comparative infectious disease approach to understanding causation in the context of the genus Bartonella, and then just a few comments before Bob begins on the BAPGM platform and Bartonella serology. Next slide. So Bartonella species are in the family Bartonellaceae, the class alpha proteobacteria. The reason these organisms were missed both in human and veterinary microbiology for many, many years is due to their extremely slow dividing time and the fact that in most individuals they are present in the bloodstream in extremely low concentrations, and as we'll see in a few minutes, not consistently there. The electron micrograph by Dorsey Cordick, a PhD student in the laboratory, is from a cat, and this is a Bartonella henselae organism within an erythrocyte. The historical importance when we were first starting to try to understand this genus is that we were all thinking of these bacteria as perhaps like Babesia or malaria, a organism that lived within erythrocytes. Subsequently, it became obvious from rodent models and in vitro studies that Bartonella could infect endothelial cells, microglial cells in the brain, circulating macrophages and dendritic cells in the skin, CD34 progenitor cells in the bone marrow. We've also looked at and published on the invasion and infection of parasites and have demonstrated infection of synoviocytes. Next slide. So a very unique feature of Bartonella is the fact that it can actually invade quite a few cells within the animal's or human's body. This phylogenetic tree of life for bacteria illustrates Bartonella on the alpha limb of the proteobacteria. I think from a clinically relevant standpoint, Bartonella are related to other vector transmitted, the Ehrlichias, the Anaplasmas, the Rickettsia, alpha proteobacteria, and also it is perhaps of biomedical importance that Bartonella are extremely closely related to the brucellas. This importance is because historically brucellas have been difficult to diagnose, that serology has not always been a dependable modality to confirm a diagnosis, and that treatment has not been particularly easy in some patients to establish that we've eliminated the infection. All of these things appear to be true of the closely related Bartonella genus. Next slide. So in the context of vector transmission, which I'll cover on the next several slides, historically, before 1990, we knew that there were two Bartonella species, one transmitted by a sandfly and the other by the human body louse. The next Bartonella for which vector competence was demonstrated was Bartonella henselae, and there's a large number of fleas that infest a large number of animals, particularly rodents, throughout the world. And it is very obvious that fleas play a very important role in the transmission of Bartonella amongst reservoir-adapted hosts. In the context of cattle, of which studies have demonstrated 80 to 100% infection rates in the blood of cattle, these organisms are transmitted by biting flies. Next slide. So one of the areas that we wandered into through a review that Sarah Billiter, a PhD student in our laboratory, wrote in 2008 was, could ticks be involved in the transmission of Bartonella species? And the reason we posed that question was between 1995 and 2005, dog and human case-based evidence was being published suggesting the possibility of tick transmission. And then there was PCR data, particularly from Europe, where investigators were documenting the presence of Bartonella henselae DNA in a number of countries in Oxodes rhusensis ticks. Subsequently, studies in 2008, published in 2008 in Emerging Infectious Diseases, and in 2011 documented in the laboratory vector transmission of a rodent Bartonella species in a rodent model. Next slide. This led us to a situation where a family in the Netherlands had contacted us relative to the possibility of Bartonella infection. The mother in this family was a human anesthesiologist. There were 4 family members, 2 of whom were sick, the mother and the son, and we were able to isolate Bartonella henselae using the BAPGM enrichment culture system from the mother, and the son's blood cultures were negative, but we were able to PCR the same Bartonella henselae strain from a stria lesion on the boy's leg, which is depicted in the upper panels there. The mother had arranged for a biopsy to be obtained, and that's in the lower left. It shows a mild degree of lymphocytic, plasmacytic, perivascular infiltration. And then Dr. Marna Erickson at the University of Minnesota Medical School was able to use laser confocal immunohistochemistry to demonstrate in the right panel there within the stria the presence of Bartonella henselae organisms. Next slide. Another vector that may be competent for the transmission of Bartonella was published by our group in Parasites and Vectors in 2013. This is a very interesting story where the apartment was flooded during a very severe storm. After the flood occurred, there was an infiltration of these little wood lice in the lower left panel there. There is a spider in the southeastern United States, and this study occurred in Kentucky, that's called a woodlouse hunter spider, and the mother saw these spiders in the house, and actually in the manuscript are pictures of bite wounds that we presumed were related to these spiders. The medical importance of this little outbreak investigation is the fact that the little boy had Guillain-Barré syndrome, was failing IVIG therapy, and in collaboration with his pediatric neurologist, we were able to demonstrate that the mother, the older son, and the younger son all were infected with Bartonella henselae, and all infected again with the same strain. Once the family was treated actually by Dr. Mosiani, there was a complete recovery of the neurological symptoms in the 3 individuals that had been sick. Next slide. Now, it's most of my career in the context of vector-transmitted infectious agents is related to tick-borne organisms. But I have become, and I want to emphasize in the next couple slides, the fact that both physicians and veterinarians, as well as the public, needs to be much more concerned about the common cat flea and obviously other fleas that might ultimately bite a human. What you can see from this particular publication by veterinarians at Toulouse is that once a flea takes a blood meal from an infected cat, it will actually transmit Bartonella henselae in its feces within 24 hours. That flea will remain infected for its entire lifespan, which is usually 12 to 14 days. And that we know from studies from more than one laboratory now that flea feces can maintain viable Bartonella henselae organisms for at least 9 days. So fleas are a very important global concern in the context of Bartonella transmission amongst animals and humans. Next slide. This slide is to emphasize the fact that cat fleas are known vectors for Bartonella henselae, Bartonella cleridiae, and Bartonella cholerae. It is also possible that they are vectors for Bartonella quintana, Bartonella bovis, and Bartonella vinsonii burkholfi genotype 2. Why that is so important is the vast majority of the research has been targeted, whether it's in veterinary medicine or human medicine, at Bartonella henselae, whereas there's quite a few Bartonella species that can be transmitted. The other important part of this particular photograph with the raccoon and the cat, which are pets of Dr. Stephen Jaffe, is that these cat fleas, although we call them a cat flea, infest dogs, coyotes, foxes, raccoons, possums, and many, many small mammals in nature that can walk through somebody's backyard and deposit eggs and larvae and ultimately result in infections. Next slide. So with almost any infectious disease, it doesn't become important until there is a family member involved. And in this instance, I want to use Bartonella cholerae, which is a documented flea-transmitted Bartonella for which cats are one of the reservoirs. And this was a situation where a young woman developed peripheral visual loss, sensory neuropathy, and hallucinations that became progressively severe and increased in number over a 4-year period. Although she had seen many different physicians, at the time we became involved in testing her, she was seeing a neurologist, a psychiatrist, and a neuro-ophthalmologist. In addition to some veterinary workers that we were testing at that point in time where we found Bartonella cholerae, she was the first non-veterinary worker in which we were able to document Bartonella cholerae by BAPGM enrichment blood culture. Next slide. So, although cats are a predominant worldwide reservoir for Bartonella henselae, you'll see from the data in Table 1 that if you test feral cats and you test raccoons, in the same geographic location, in this instance Georgia in the United States, you find an identical bacteremic presence for both Bartonella henselae and Bartonella cholerae. In this instance, Bartonella chlorigiae was only found in the feral cats and wasn't found in the raccoons. What I've also listed on this slide are mongoose, which there's data from several laboratories now to support that they can remain bacteremic for long periods of time. And then all the opportunistic or accidental hosts in which Bartonella henselae has been either cultured or DNA of the organism has been PCR amplified from a tissue. Next slide. So since our research on Bartonella started back in 1992, this genus has become a major problem for veterinary medicine. And the reason is veterinarians are responsible for the health care of all the animal species on the planet, and we are also very concerned about any organisms that can infect both animals and people. Next slide. And this is just one example of many that I could have used in this particular presentation, but Riccardo Maggi had made 2 isolates during our IRB-approved studies on human Bartonellosis. One was from a woman living on a sheep farm in Southern California who had pericarditis, and the other was a woman who had visited family in Ohio, apparently had received a bite wound to her medial thigh, developed a large maculopapular lesion, and then after that developed a chronic illness. We had these isolates in the laboratory. We knew that based on DNA sequencing of several genes that they were a Bartonella, but they didn't match anything in GenBank at that time until Michael Kasoy at CDC deposited sequences from sheep GEDs and David Bemis from sheep blood. So here we have an organism that has co-evolved with KEDs, a wingless fly, as the vector for transmission, can persist in sheep blood for long periods of time, and can make the jump by mechanisms or modes of transmission that are certainly poorly understood from an animal to a human. Next slide. So in 2004, Merrill and Stanley Falco published a paper in Nature where they highlighted the importance of looking at disease from the standpoint of frontal pathogens and stealth pathogens. And they actually featured 2 organisms, Helicobacter pylori and Bartonella henselae, as stealth pathogens. Now, at least 10 years later, we know that many of these Bartonella species have very prolonged incubation periods, both in reservoir and non-reservoir hosts, that they induce chronic bacteremic infections, that immunity is not sterilizing, that transmission can be indirect through an arthropod vector, that replication, as I mentioned in the first slide, 12 to 24 hours is extremely slow, and that we have reservoirs or carriers that are out there in nature throughout the world. Next slide. So this is going to be our one slide on pathogenesis, and what has happened in very recent years, literally within the last year or so, is that we've come to recognize that there is both a dermal phase of Bartonellosis and a vascular phase of Bartonellosis. How long and where this organism persists in the skin and dermis is yet to be decided, but once it is transmitted by a vector through a break in the skin or through a bite and enters a dendritic cell and then targets the endothelium, it then causes what is depicted in the timeline at the bottom of the slide, a relapsing pattern of bacteremia. I'll remind everyone that trench fever was called 5-day fever, that Christophe Dieho's group have shown in the laboratory in a rodent model a relapsing bacteremia. And next slide. And as you'll see in just a minute, we've demonstrated this many, many years ago in cats that they develop a relapsing bacteremia. So this dermal involvement in Bartonella, we looked at the stria lesion in the boy from the Netherlands earlier, and this published in Veterinary Dermatology last year is a situation where we were contacted because the dog had nodular paniculitis. Nodular paniculitis is a granulomatous inflammation of the dermis. It occurs in dogs, humans, and other animals, and we and others have previously documented Bartonella infections in association with this particular form of skin pathology. In this particular manuscript, the dog was PCR positive, and we were able to document the presence of the organism by immunohistochemistry, by direct immunofluorescence, actually in the dog's lesion. For the man, the biopsy was a superficial shave biopsy, so we could not confirm whether this was paniculitis or not. The picture of the lesions on the arm there. But again, we were able to isolate the organism through BAPGM enrichment blood culture. Importantly, as has been true of approximately 50% of dogs and 50% of humans that are persistently bacteremic, both were seronegative and did not have antibodies to a panel of 6 different Bartonella antigens that we use on a research basis. Next slide. So now we're going to drop back to 1992 when Russ Rigneri at the CDC made the association between Bartonella henselae, a new bacteria isolated from an AIDS patient in Houston, Texas, and cat scratch disease. And I'd like to suggest to everyone listening that cat scratch disease 1 is the tip of an iceberg based on what's occurring in the literature and what's been found. I would suggest that these bacteria can cause endocarditis, granulomatous inflammation, chronic intravascular infections, and may be a cause or cofactor in vasoproliferative tumors. And I refer everyone to this particular manuscript where human microbiologists, pathologists, and veterinary microbiologists, pathologists proposed a new postulate to look at stealth pathogens in the context of chronic disease causation. Next slide. So when I lecture, particularly to veterinarians, I suggest to them that the dog's the best naturally occurring model for human Bartonellosis, and that veterinary workers are the best naturally occurring model for canine Bartonellosis. And I say that because as you look at the literature, the disease processes that we're seeing in dogs naturally infected with the Bartonella species are very similar or identical to what we're seeing in humans. Next slide. So we're going to jump back to David Relman's publication in the New England Journal of Medicine in the 1990s. And just to make a comment that if it were not for AIDS, we would not be having this webinar today. And I'm relatively confident that we might still not know that the genus Bartonella infected animals or humans, at least on the North American continent. So during the late 1980s and early 1990s, these lesions were recognized by pathologists, microbiologists. The pathologists with silver stain could see the organisms, but the microbiologists were having difficulty isolating the organism, and David Relman used PCR, eubacterial primers, and DNA sequencing to say that if you had these lesions, it was either Bartonella henselae or Bartonella quintana. Next slide. So again, from the standpoint of comparative medicine and One Health, this is a papillon that was being treated by a veterinary internist for pancytopenia. I would mention that Bartonella is the only bacteria that is known to infect CD34 progenitor cells in the bone marrow, and this may ultimately prove to be of clinical importance because we've seen just neutropenia, we've seen pancytopenia in a small number of individuals that will have a reversal in their hematologic abnormalities following appropriate therapy. But the important part of the message for this particular dog is that the dog was being immunosuppressed. The dog developed cutaneous lesions. A veterinary dermatologist biopsied the lesions, sent it to Julie Best, Jaeger-Best, who documented that this dog had bacillary angiomatosis histologically, And Mardula Variant, a PhD student in my laboratory, then got involved and was able to culture Bartonella vinsonii burkholfi genotype 1 from the dog and to get the biopsy PCR amplify the organism, the same organism from the biopsy, and then demonstrate the organisms by Werther Starry stain and eubacterial primers. Next slide. So it's beyond the scope of what we can talk about today, but probably the most intensive research into the pathogenesis of Bartonellosis has been related to vascular endothelial growth factor production and the stimulation of vasoproliferative lesions. We've been able to identify humans infected with a unusual and infrequent tumor called an epithelioid hemangioendotheliomatosis from Australia, England, and the United States. And we've been able to show that you can look at a tumor such as an hemangioparasitoma in dogs, horses, and a rib wolf and find the same organisms, Bartonella vinsonii burkholfi, in all three individuals. So again, I think using a comparative approach to demonstrating the presence of DNA in tissues or isolating the organism from patients with similar disease processes can be very useful. Next slide. Now, I want to use this as an example of how what was published in the human literature prior to us even knowing that cat scratch disease was caused by Bartonella henselae has been useful for us to look in our veterinary patients to find similar disease processes. So atypical cat scratch disease is considered granulomatous hepatitis, osteolytic lesions, particularly in children or AIDS patients, atypical pneumonia, hilar adenopathy, pleural effusion, and thrombocytopenic purpura, or ITP. Next slide. So Natalie Cherry, a PhD student in the laboratory, was able to grow or at least enrich through the BAPGM platform several Bartonella species, including Bartonella henselae and Bartonella vinsonii burkholfi, with dogs that had very difficult diseases for us to manage medically, including chylothorax, lymphangiectasia, restrictive pericarditis, and polyarthritis. Next slide. Excuse me. Now, again, we were contacted by Sylvia Fernandez and her collaborators at the Fox Chase Cancer Center because they were studying effusions from women with an aggressive form of breast cancer called inflammatory breast cancer. And what they had isolated from 2 of their patients that had failed multiple chemotherapies was a gram-negative bacteria that they could stain in their cell culture system by Werther Starry silver stain. The DNA from the culture system and bacteria was sent to us. Riccardo Maggi performed PCR targeting the intergenic spacer region with several different primer sets, and the sequencing confirmed Bartonella henselae. When they used a monoclonal antibody to Bartonella henselae in an indirect immunofluorescent assay, they could actually demonstrate fluorescence within the nucleus of these tumors. Next slide. So I think the important point here is from cat scratch disease and infusion to dogs with pathological effusions to a human, excuse me, we were able to see a common form of pathology and find the same bacteria. This is, again, another contribution from Mardula Variant, the PhD student in the lab, in which we were able to isolate Bartonella from a cat with osteomyelitis. Next slide. Mardula, the other, again, from a comparative standpoint, we have described myocarditis in dogs. There has been the suggestion that orienteers in Sweden that died suddenly and unexpectedly, had myocarditis potentially associated with Bartonella infection. And this is an example of granulomatous myocarditis in cats in which, next slide, Mardula was able to PCR Bartonella henselae, a Cal1 type strain, which we don't see very often, from the heart muscle, which is illustrated in the upper left panel with a granulomatous lesion. Our pathologist, Keith Linder, could demonstrate this by Warthin starry silver stain. Again, with a monoclonal antibody and immunohistochemistry, we could light these organisms up. And with eubacterial primers, we could demonstrate that there were bacteria within the granulomatous lesions in the cats. Next slide. So probably one of the most convincing areas in the context of causation is bacterial endocarditis. And what's important on this slide, again, is the dog is an exceptional animal model for human Bartonellosis, and the human an exceptional model for animal Bartonellosis. And what you can see is essentially the same Bartonella species have been identified in both dogs and humans. Next slide. So this is when I saw this particular dog, whose name is Tumbleweed, as a patient. I didn't realize that this dog, a 3-year-old Labrador, would actually change my life and change my career. And over a 1-year period, Tumbleweed progressed from polyarthritis to weight loss and seizures and vasculitis to epistaxis and endocarditis, with the heart valve on the right involvement of both the aortic and mitral valve, essentially bivalvular endocarditis. Next slide. So how did we end up with the first dog isolate in the world from this rather young Labrador retriever with a history that spanned 1 year? The reason was the dog was positive for anti-nuclear antibodies, similar to the dog that I showed you earlier that was being immunosuppressed and developed bacillary angiomatosis. Tumbleweed was immunosuppressed for the presumption of an autoimmune disease, and the laboratory consequence was that we were successful using lysis centrifugation blood culture at that point in time in coming up with the first worldwide isolate of Bartonella vinsonii burgdorferi. Next slide. After that, what we figured out over about a 6-year period with Brandy Pappalardo as a PhD student in the laboratory was isolating Bartonella from a dog was going to be far more difficult than isolating Bartonella from a cat or an AIDS patient. And we literally banged our head against the wall for several years until we came up with the question, will an insect tissue culture medium enhance the growth of a fastidious bacteria? And the answer to that question proved to be yes. Next slide. So at that point, Sushama joined Health Canada, and Ricardo Maggi joined me in the laboratory as a research scientist. And these publications, starting in the upper left, was initially to look at our gene target, which we figured out that the original primers that we were using, although they work great in cats, were not as specific as we thought, and Ricardo rectified that problem. Next, he proved that using an insect biochemical composition growth media, that you could, by looking at growth kinetic curves, grow Bartonella species more readily than using mammalian growth medias. And then Ricardo and Ashley Duncan, a PhD student in the laboratory, went on to test this combined approach of enrichment culture followed by PCR using in excess of 150 dog samples from sick animals that were referred to North Carolina State University. And that was published in the Journal of Microbiological Methods. Then Beth Pertulik, a PhD student in the laboratory, reviewing our human data, which we'll get to here in just a second, figured out pretty quickly that we needed to go from a single-day collection to a 3-day collection to be able to identify these organisms. Next slide. So this is what we refer to as enrichment PCR, the BAPGM platform. And what it basically says is that we have developed one of the more complicated microbiological approaches which in our hands is necessary to try to prove or disprove that there's Bartonella in the blood. And again, this would be what would happen to a single blood sample over time and the different steps along the way, realizing that we now know that whether you're a cat, dog, horse, or human, that doing 3 samples will improve our sensitivities, depending on the animal species, somewhere between 10 and 25%. I can also tell you, as you look down 7 days, 14 days, and 21 days, that when we test horses, we never get a positive sample PCR from an original sample, a 7-day culture, a 14-day culture. We always have to incubate for 21 days. Next slide. So what Dr. Mosiani is going to discuss is the fact that once we develop the BAPGM platform, and my lab, in collaboration with Chris Woods at Duke, started an IRB study, we figured out pretty quickly that veterinary workers were occupationally at risk for infection with these organisms. Next slide. And so I think my conclusion after chasing the genus Bartonella for 20 years is that currently the BAPGM enrichment blood culture triple draw is the optimal diagnostic confirmatory test for blood. We have isolated, using this same approach, Bartonella from joint fluid, from cerebrospinal fluid, and as I showed you, from pleural and pericardial effusions. Bartonella serology, for reasons that remain unclear, have limitations in patients that are persistently bacteremic. Clearly, if there are paraffin blocks, tissues, or fresh tissues, preferably PCR, indirect fluorescent antibody studies, immunohistochemistry, and FISH can be utilized on infected tissues. But it's important for everyone to realize that each of these testing modalities has limitations, and that in our experience, a combination approach is frequently required to achieve an accurate diagnosis of Bartonellosis. Next slide. So I'm going to quickly go through this case of a 52-year-old veterinarian with progressive weight loss and a poorly defined lesion on MRI. Before our testing, this individual was being seen by the neurology service at the University of North Carolina Medical School, and his daughter, about 2 weeks prior to our testing, was pulled out of school because of severe headaches, muscle pain, and insomnia. The mother and 2 sons were healthy and had not experienced any medical problems, and they were BAPGM blood culture negative. Next slide. So this veterinarian was infected with Bartonella vinsonii burkholfi genotype 2 and Bartonella henselae Houston 1. What he illustrates and what we have seen, and you'll see that he actually was negative in blood on 11.5 and negative in blood negative in blood and cerebrospinal fluid by direct PCR from these samples, but with enrichment culture was positive with both, and after treatment was positive for Bartonella henselae. Next slide. And this is typical of our experience with some patients in which the daughter was only positive with enrichment culture, and we were fortunately able to make an isolate from this young lady. Next slide. And this is the last story for me before turning it over to Dr. Mosiani. And this is, again, a very fascinating event that we were able to follow through our IRB approved research. And this begs the question is, can a canine histiocytic tumor in a dog contain viable Bartonella organisms? And the answer to that question appears to be yes, because this veterinarian diagnostically aspirated a histiocytic or lymphocytic undifferentiated epithelial tumor from a very fractious dog and managed to stick the needle into her hand. She never seroconverted to Ehrlichia, and she remained PCR negative to Ehrlichia, and the reason that was a question was because the dog had been diagnosed with Ehrlichiosis and treated with doxycycline 5 months earlier. Next slide. What you can see here is that she was initially healthy. She then developed headaches and paresthesias. We had a positive PCR by direct extraction at day 33 with a negative enrichment culture. It's the reason we always test blood, serum, and enrichment culture. And by day 81, she's negative by direct PC extraction from her sample and positive by enrichment culture, and seroconverts to a titer 1 to 128. Next slide. Next slide. So in conclusion, and I will apologize at this point for us getting started a few minutes later due to technical difficulties on my end here, I do consider the genus Bartonella to be a very substantial One Health problem for veterinary medicine and human medicine. And I think if we look at the number of reservoirs, the number of vectors, and the number of Bartonella species, this becomes very important.
All right, bye. Okay. What does she need?
Next slide.
What is she coming back?
And so for my final slide, I would just like to acknowledge that many of the people depicted in this slide are PhD students, postdoc scientists and research associates and technicians who have facilitated the work. The references are listed at the bottom of each of the slides, and this webinar will be posted after Dr. Mosiani finishes. Thank you very much.
Okay, thank you very much for that presentation. I see that there's actually several questions coming in, but as a reminder, we're going to hold the questions till the end of the presentations. And we're now going to turn the microphone over to Dr. Bob Mosiani. Bob's topic is Bartonella, clinical expression of small vessel inflammation. Bob, give us a second. We'll get your microphone open, and then you can instruct us when to go ahead and advance your slides. Okay, Bob, right. I think your microphone is going to proceed whenever you're ready.
Testing. Great. Welcome, everyone. This has been quite a journey working with Ed Breitschwerdt and his team. I regularly see patients with various chronic illnesses, and this has been one of the single biggest insights by far into the care of these patients, and has made very large differences in many people's lives. So I'm very, very happy and excited to be part of this One Health collaboration. Next slide. So we've gone over the disclosures, but I just want to emphasize that my role with Galaxy began after we did our clinical study together between my practice and NC State. The medical practice is called the Translational Medicine Group, and recently we formed a foundation for the study of inflammatory diseases that will be operating a Bartonella registry. Next slide. The objectives are to explain chronic clinical manifestations of Bartonella as small vessel disease, discuss neurological manifestations of small vessel disease, discuss foundations of diagnostic testing, review general principles of possible therapy, and provide clinical insights to prioritize research. Next. In the clinical setting, we often see patients with varied and somewhat severe and often very limiting either individual symptoms or symptoms in combination. And there's considerable variability among patients who may have the same infection. And I want to remind everyone that this debate as to whether or I should rephrase that, the degree to which a germ contributes to the disease versus the host response is a debate that was held even between Louis Pasteur and his colleague Beauchamp. So what we call autoimmunity may in fact be to some or to a large extent due to an infection either triggering a process or persisting, and even very low levels of persistence can perpetuate autoimmunity. My research background is in autoimmunity, and particularly the molecular biophysics of peptide MHC interactions. Next slide. The pathogen, host, environmental factors all contribute and combine to determine disease. So if a germ is highly pathogenic, the disease is usually more homogeneous in its presentation. If it's low pathogenicity, stealth, low grade, it's more chronic, and it presents as various chronic illnesses, which then are in the domains of other specialists than those who practice infectious disease. Next slide. So we have considerable overlap, for example, with Bartonella and Lyme disease. And as we all know, Lyme is a controversial question, but there are many unanswered questions within that field. And as I work with these patients, I was very interested to determine if there was better testing available for one of the co-infections of Lyme called Bartonella. And so having started to look at that across these patients, I began to appreciate how often that could be contributing or, in fact, even confusing the diagnosis. There are many more ways to get Bartonella than Borrelia, so there's a considerable overlap. The degree of it isn't entirely clear, but we sought to try to answer that question in our earlier research. Next slide. So briefly, and I won't dwell on this too long, but I want to mention a little bit about this overlap. Bartonella is known as a co-infection of borreliosis, and I use a very narrow definition of Lyme, specifically as borreliosis. And I try to dissuade patients from using the term Lyme disease because I want to be very specific about what they may or may not have. However, Bartonella itself is its own issue. I found in patients that it is especially prevalent when the neurological and neuropsychiatric findings are present. And in general, in the category of patients who may have failed treatment, this seems to be one of the important things to look for. Symptoms mostly are related to the effect it has on small vessel inflammation. And what we have found more recently is that the Bartonella is also present and bound to collagen. And of course, testing helps clarify the relative contribution of the various co-infections. So as the diagnostic tests improve, we will be able to better discern what's there and therefore determine what is contributing to the symptoms. Next slide. Next slide. So the primary infection strategy of Bartonella is, as Dr. Breitschwerdt reviewed, there's a dermal phase and then an endovascular phase. And we had been thinking about Bartonella as primarily an endovascular and bone marrow infection. And of course, many of the manifestations symptomatically are from the effect it has on the small vessels. But because there is a dermal phase, we pursued imaging studies actually led by Dr. Erickson at the University of Minnesota, which I will show you later. But we now know that Bartonella does infect outside of the vascular system and can be found in biofilms on collagen. Next slide. So this is a picture that I find very helpful in explaining to patients how they get such a wide variety of symptoms. When you have an infection, pretty much any infection, you'll get inflammation. And then you can get fibrin deposits on the endothelium. And in this slide, the red is a stain for fibrin. And then you can also think of those fibrin deposits as biofilms. And then if the vessel is small enough where this is happening, that vessel's flow will be limited. So this is for example, a small arteriole. It's only a few red cells in diameter. And you can see how with the inflammation on the right, particularly because it blocks the endothelium, it's going to limit energy delivery and nutrient delivery to the endothelium and thus reduce the production of nitric oxide and then result in vasoconstriction, which would then create symptoms depending on what tissue that vessel is feeding. So typically patients will come in and describe a wide variety of symptoms, but I see each of those as a pixel in a picture, and that picture speaks to me small vessel disease. Unfortunately, we don't have a single diagnostic test for small vessel disease, so it's an entirely clinical diagnosis with some features that I will describe momentarily. Next slide. So here's a patient who we believe has Bartonella, and you can see in the red cells there are just inside the margin of the red cell there are these round clear structures We did not silver stain this. This is just a regular diff quick stain. And you can see in the middle a darkly stained round object. That is a biofilm. It's an older one, not freshly forming. And you can see it's part of a broader biofilm, because that haze that you see covers those red cells that have these round forms along their margin. That whole haze is a larger biofilm. So when you look very carefully at the blood smear, as I do on every single patient, using a research-grade microscope with advanced optics, I can very easily discern these and understand better how to manage the patient. Next slide. This is a published photomicrograph from our French colleagues, and what you can see here are their demonstration of the way Bartonella looks, and I just put this up to demonstrate the similarity in the images. But what is not stained here is the biofilm that probably is spanning across those red cells. Next slide. This is from Dr. Erickson at the University of Minnesota. It is a picture of a skin biopsy obtained from a non-lesional area of a patient who had been sick for quite a while. And what you'll see in the next slide is a magnification of that zone. Next slide. Showing the staining positive by immunofluorescence for Bartonella. So we now know that the Bartonella does live on collagen, and I've got a few more pictures to show you. Next slide. And in this particular case, a confocal image of a lower leg skin biopsy that was acquired before treatment shows some interesting findings. First of all, I want to say that the patient had been ill for 2 years before diagnosis. The biopsy was from non-lesional skin. The Bartonella henselae is in red, and the other gram-negative staining that you see is for other gram-negative coccobacilli. So Bartonella is not the only microbe present, and the other ones may be those that are acting in a biologically similar way and possibly from a similar phylum. The patient was blood PCR positive for three strains of Bartonella, henselae, Vinsoni, and another that we suspected was likely Bartonella cholerae. The bacterial staining was absent in the control. The control was one in which the antibody phase was left out. And there was much lower Bartonella henselae immunoreactivity than the general gram-negative stain with polymyxin, which is staining green. And finally, our conclusion from this is that the bacteria are more closely associated with vessels and lymphatics and not with nerves. Next slide. This is a multi-photon image contributed by Dr. Erickson, and what it's demonstrating is, in the green blotches, colonies in biofilm of Bartonella on collagen. So we now know, and this helps us explain the symptoms people develop as we treat them, which include various aches and pains, and it may well explain what we often see clinically, which is the nodular paniculitis actually developing during antibiotic therapy. Next slide. Okay, next slide. So let's talk more about small vessel disease, because it was by a careful neurological exam that I first began to select patients for testing, and it was in that group that we began to see the high prevalence of Bartonella. So small vessel disease can be anywhere through the entire vascular system, and just to remind all of us, that's where most of the action occurs with regard to gas exchange, metabolite removal, and nutrient delivery. So the the mechanisms can be ischemia reperfusion. Cells that are injured in this way often may not be dying or dead, but they just simply may be dysfunctional or stunned. In the heart, that could be stunned myocardium. In the brain, it could be a neuronal issue. And the symptoms can potentially be anything, depending on how the tissue or organ is disrupted. And depending on the part of the brain that's affected, potentially any neuropsychiatric symptom. Next slide. So how do you know a patient has small vessel disease? There is no good direct diagnostic test that will give you a number, and it's a clinical diagnosis. And your most sensitive system to explore by exam is the neurological system. The nervous system with components obviously related to the central nervous system and the peripheral nervous system provide a very sensitive network of sensors and tripwires, so to speak, that one can observe for evidence of microvascular compromise. And I would also say, and this is an important point, that the white matter areas of the brain don't have collateral flow. They have specialized features for nutrient transport, and a blood vessel that penetrates into a dense white matter area is highly vulnerable because it's the only way in and out of that area. So if you have small vessel inflammation and it affects a deeper perforating arteriole, then you're much more likely to have neuronal lesions related to white matter and the function of the interconnecting fiber bundles than you would where the cell bodies are in the gray matter. So disconnection syndromes are what we call them, and I'll explain that a little further. Next slide. So the central nervous system features can include, and most commonly include, mild cognitive impairment. There's a neurological term called the subcortical disconnection, where the different parts of the brain are not interacting well. Executive dysfunction or executive function is impaired, and people have a hard time often doing slightly more complex tasks like sorting, prioritizing, organizing, arranging their affairs. They might look at a pile of paper on a desk and not even, and have no, just intuitively know that there's no way they can go through that and try to sort it out. It's not a true dementia because with extra effort, they can do it. Their working memory is impaired, so it takes longer to do everything that they do. Their processing speed is delayed as a result, and because partly the frustration of having a slow brain, they have generally increased difficulties with social interactions, information processing, and keeping up with their needs and their affairs. So their mood can be labile for a wide variety of reasons. And this can make it very difficult to work with some of these patients. So as I've often said to patients and staff, we need the patience of psychiatrists, but with the internal medicine knowledge to manage them properly. Next slide. Next slide. So again, the nerves are the most sensitive tripwires. White matter areas of the brain are vulnerable, and they're watershed areas where there's no good collateral flow, and any level of small vessel inflammation can bring compromise. Next slide. There is a nice review of various patients with a variety of different neuropsychiatric manifestations, and I would refer you to this publication for that review of multiple cases. Next slide. So in addition to the central nervous system symptoms, there are non-central nervous system symptoms. So for example, first and foremost, peripheral neuropathy. This is characterized by the neuropathy being migratory and fluctuating. Unlike a neuropathy where there's been permanent damage to a nerve, this neuropathy is related to transient episodic vascular compromise, and so patients will describe it as the the symptom moving around. Well, the process isn't moving around. The process is going up and down in different locations, much like flashing lights that are kind of randomly going off and on. There is also, if it's affecting the peripheral nerves, we have to remember that the autonomic nervous system also has a peripheral nerve component, and you can therefore get dysautonomia, dysregulation of heart rate, blood pressure, etc. And many patients have a condition called POTS, postural orthostasis and tachycardia syndrome. They often will have a low pulse pressure because their diastolic pressure is a little high because things aren't flowing well in diastole. And the whole condition of POTS is quite interesting because the vascular tone is a function of, well, the vascular tone has an elastic component, which is related to collagen, and it has a dynamical component related to the tone of the smooth muscle. So with inflammation, you'll get diminished tone from smooth muscle, and in a patient, for example, who may already have a hypermobility syndrome where their collagen fibers are literally more elastic, they will be more likely to manifest the condition called POTS. There are also focal transient muscle spasms and fasciculations. There may be muscle pain. There is joint pain, arthralgias in and around the joint, headaches, fatigue, decreased stamina. Next slide. This is an instructive case I had. This patient is a veterinarian, and she had extensive childhood exposure to fleas and cats, as well as occupational exposure. We isolated all of these strains from this individual. She was very helpful and eager to be tested monthly, so we probably have more data on her than any other patient. And of note, there was a cyst in the breast. It was diagnosed as a benign fibrocystic breast cyst, and it she asked for an aspiration and culture, and all of her physicians at a prominent hospital in the U.S. refused to put a needle in and aspirate it. Finally, we found a surgeon who was willing to do that, and it was positive on PCR, enrichment PCR for Bartonella. This patient also had acquired hypermobility syndrome. She did not grow up with it. It was not genetic. It developed later. And so this speaks again to the injury to collagen that may occur. And in addition to the hypermobility syndrome, she had articular pannus of the wrists and elbows, was scheduled for a correction and resection of the pannus, and that ultimately never happened because during treatment the pannus regressed and she was able to return to having most of her function. I will note that this patient also went on to have a very successful pregnancy with a healthy child, but I'll speak to that a little later. Next slide. In this particular patient, the antibody levels at the beginning, before treatment, despite the fact that she had multiple confirmed infections with Bartonella, the antibody levels were entirely negative. After starting antibiotics, the central nervous system symptoms and her energy improved over the first few weeks, and then several weeks into treatment, she began to develop diffuse joint aches and pains. And for a while, I thought that was an immune complex, particularly, and I'm sure it is in part, because for a little bit of time, the antibodies disappeared entirely, and then they kind of came back up again a little bit, and then they disappeared entirely. And several months after all the antibodies again resolved, we cultured her again, and she had, at that point, positive, she was bacteremic for Bartonella henselae. And so we gave her a second course of a different antibiotic combination and has done well since then. Next slide. So now segueing to the paper that reviewed 296 patients whom I had evaluated, and initially I was selecting them based on, I was selecting them for Bartonella testing based on whether or not they had they had evidence of small vessel disease on their neurological examination. Next slide. My experience in this goes back to an extensive, best term for it is probably sabbatical, to develop transcranial Doppler methods to study small vessel disease and cognitive impairment and learn how to examine patients for central nervous system signs of small vessel disease. With that awareness and knowledge and information, I was looking for those features in patients with chronic symptoms, many of whom felt that they had chronic or post-Lyme syndrome and had failed treatment. So in spring 2008, to elucidate the cause of the small vessel inflammatory disease in these patients, we began to search for better tests for chronic Bartonella, and I found that the generally available commercial clinical labs testing was entirely unsatisfactory. In fact, I can't recall a case in which I had a positive test result from a commercial lab for Bartonella antibodies. In fall 2008, we began collaboration with Dr. Breitschwerdt, and then one day I got a phone call from him that he was seeing a higher prevalence in our patients than he had seen in any other group, including high-risk veterinarians. Next slide. So the patients included 205 women, 91 men. I had mentioned that many of them had failed Lyme treatment, so in my view, they really didn't have a diagnosis. Weren't sure if it was Borrelia or not, but we were there working with these very sick patients to try to find some solutions for them. The central nervous system small vessel disease exam findings selected a population with a high prevalence of Bartonella antibody, and so I'm always asked, how did you discern these patients? And it all comes down to an explanation and teaching of small vessel disease and how you look for it clinically. That's very important, and it's something that just has to be taught. There isn't a test for small vessel disease yet. Next slide. This is just a repeat of what we covered. Next slide. So we found in these patients, and again, even though we currently believe that the optimal testing is a triple culture, 3 specimens over a couple of weeks, in those folks in this study, we only did 1 culture and checked the serologies 1 time for almost all of them. And so with a single culture, we found that 41% were positive. The serology was positive overall in 185 and 62.5%. And of those, 75% had at least 1 cross-reacting IFA test result. So what we found is when they're positive for 1 IFA to 1 Bartonella, they are often also positive for another. Next slide. So we looked at the Bartonella bacteremia as a function of their reported conditions, and we found that about 33% of those who felt they had Lyme disease were positive for Bartonella. Again, these are self-reported diagnoses or based on whatever they had personally experienced or others told them they had. Of those who had reported psychiatric issues, 50% were positive, and those with neurological disorders, although the denominator gets to be pretty small, about 85% were bacteremic. Next slide. The presence of Bartonella henselae correlated significantly with blurred vision, numbness, i.e. the peripheral neuropathy, and consultation with a neurologist. The Bartonella cholerae did not, and they correlated with having seen an infectious disease physician. We don't really understand that correlation. Next slide. And this Venn diagram just goes to show you how the yields by enrichment PCR differ across the specimen types. And so approximately 50% or so are positive in blood, and then there are others who are positive just by culture, and then others only PCR on serum. And so the diagnosis of this microorganism has to be based on triple cultures, and ideally, and also different modalities looking at blood serum and blood after culture. Next slide. Now, comparing the rheumatology population to the high-risk population, there are some differences. The Bartonella henselae is slightly higher, and you'll note that in both of these it's higher in those who are IFA negative. So having some antibody seems to reduce that number. The Bartonella cholerae is a little higher in the high-risk population, and the Bartonella vinsoni genotype 1 and sometimes 2 was seen in the rheumatology group, but it was much more common and prevalent in the high-risk population. Next slide. Go ahead. So, again, this is just an overall description, excuse me, of the two groups. And then finally, there was another study in control subjects who had a very low prevalence of antibody, and so we know that it's not present in significant numbers in those who are ostensibly healthy. Next slide. So in the when you look at the PCR positivity in the high-risk group compared to the rheumatologic group, you can see that that the PCR positivity is higher in the rheumatological group for whatever reason. We don't fully understand. Next slide. And now a word about the potential, or I should say the possibility of perinatal transmission. So this is a case of that Dr. Brycewart worked very closely with, and they looked very carefully at the parents as well as the children, and maybe later Dr. Brycewart can speak to that further, but I put this up to demonstrate that it is possible to transmit this transplacentally or perinatally. However, next slide. So my own experience is that over the last 5 years we've had 6, now kind of going on 7 pregnancies in women who became pregnant at various times, or various time points in the course of their diagnosis and treatment. So in the in a few cases, they became pregnant more or less right at or shortly after diagnosis, and in a few others, it was after the infection had been treated. In every case, we obtained umbilical cord blood, and all of them were negative to date. And when I speak to the parents periodically for follow-up, I always ask about the children, who all seem to be doing well with no reported abnormality yet. And the oldest one of these is probably, at this point, 5 or 6 years old. So I think that the probability of transmission is low, or there's something about the neonatal immune system or physiology that is able to control this microorganism. Given how common it may be, there may be some built-in evolutionary defense systems that are operating, and so while one needs to consider it, I usually tell my patients to not worry about it that much. So yes, there can be very severe and bad cases, but the probability so far speaks to it being a less likely scenario. Next slide. So my clinical insights from having evaluated hundreds of patients with Bartonella is that they generally have a positive outcome, and there's a relatively uniform time course of response to treatment with a resolution of most symptoms after a period of symptom flare-up in the early phase of treatment. So the way these folks respond to treatment, the timing in particular, seems to be much more homogeneous than their initial presentation with symptoms. So I think this goes back into the causation argument and an updated, revised view of Koch's postulates. The question of endocarditis is looming because those who have valvular endocarditis tend to get a very severe form of endocarditis, ultimately leading to valve replacement. So I'm always vigilant about it, but having for a while done echocardiograms on most of the patients, I have never seen any evidence of valvular disease other than mild murmurs, and none of them seem to progress. However, I currently have the patients do a baseline regular transthoracic echo, and then several months later during treatment or before treatment's over, I have them check again. So it's hard to know how vigilant to be about this because the complications could be so severe if they occur. I think it's better to err a bit on the safe side, but again, I don't think it's very, very common. There are, however, cases of very, very healthy people, athletes, who suddenly got exposed and suddenly developed severe valvular disease and had to undergo valve replacement. So again, those experiences keep us on our toes. I don't think, and no one thinks, that transesophageal echo is the best way to look at valves for endocarditis, but I think it's a little too much to have every patient with a suspected case of Bartonella undergo a transesophageal echo. So I think we need a little bit of a better algorithm in that regard. Liver cysts, when observed, resolved with treatment, and I mentioned the benign breast cyst aspirate that was positive for Bartonella. There was one other individual patient who had 2 kidney cysts, and I don't have any data. We didn't tap it, but the question came up as to whether or not a cyst could be a risk factor for relapse, and if the presence of the cyst would be a reason to prolong treatment. Next slide. With chronic cases, the endocrine dysfunctions are very common, and this is an approach that some people call functional medicine, which is to appreciate that the adrenal isn't a binary organ. It's not in a state of being totally on or totally off, but that there are levels of adrenal output and dysfunction. If you have a long day and don't sleep too much, you will have less cortisol the next day. Well, this happens day after day in these patients. And so they develop a condition we call adrenal fatigue. Now, that's an issue in and of itself, and they can be helped a lot by looking at that. But the real problem seems to be when we use the antibiotics. Because if we use rifampin as part of this protocol, rifampin's an inducer of cytochrome P453A4, and that will induce the metabolism not only of cortisone or hydrocortisone, but also estrogen and testosterone. By the way, it also induces the metabolism of that cytochrome, which is involved in the metabolism of about 50% of all prescription drugs. And so if they're on hormone replacement therapy, for example, you have to watch this because the dose of that may need to be doubled, tripled, sometimes quadrupled while they're on the treatment. And so this is one of the important points to consider because the rifampin treatment can backfire and you can get a very sick patient way beyond any inflammatory flare-up if this is not considered and carefully managed ahead of time. These patients also have, because of the inflammation, they have a condition we call euthyroid 6 syndrome or hypothyroidism type 2, where they will typically have some reverse T3 elevation. Some people would look at the ratios of free T3 and free T4. This is very common in patients with chronic inflammation, and it's almost always missed, and there are very few endocrinologists who are even willing to diagnose and manage a patient clinically. They always insist on lab testing, but these patients often have normal thyroid lab results. This is not just, by the way, for Bartonella, but any kind of state of chronic inflammation, even chronic food allergies can cause this to happen. Next slide. The complications that may occur during treatment are related in large part to an understanding and appreciation of how these antibiotics affect metabolism of hormones and drugs. When we treat for Bartonella, especially when they're aching more, they're having arthralgias. Their lab tests will show typically a mild to moderate depletion of the neutrophils. And this is one way I can tell whether what they have is really a response to the antibiotic as we kill off the germs. At the same time, they will experience a rise in liver function, particularly the AST and ALT, transaminases. But this is not persistent, and nor is it an antibiotic toxicity. This is probably from the antibiotic killing Bartonella in and around liver cells, Kupffer cells, etc. So while initially I would stop antibiotic therapy when I saw this out of concern and caution, I have since decided to just push through it, and for the last few years we've been doing that with no adverse consequence, because these liver enzyme elevations are self-limiting. They're not from toxicities from the antibiotics. And again, the need to do functional medicine with adrenal assessment and clinical management in that order. Next slide. Now, one of the things we, as I've said, you get deep pain in connective tissues a few weeks after adding the second antibiotic in the protocol. That antibiotic is usually rifampin. And sometimes that happens after we double the dose, and I'll explain the protocol in a short while. This may partly be a serum sickness and partly from the die-off of Bartonella, to which then there's an immune reaction at the collagen level. Next slide. The principles of antibiotic use that I've considered in devising our protocol is that it has to be of sufficiently long duration. It's so extensively found in various connective tissues, bone marrow, etc., that I don't think short courses are adequate. We don't know what the optimal duration is, but as with antibiotic protocols for many chronic infections and many acute infections, including things that are routinely seen, like pneumonia, it's really hard, and you don't have too much data to show you whether or not you should do it for 14 days or 12 days or 10 days. So when we come up with a protocol that works, we tend to stick with it. And a lot of the decisions here and selection of the antibiotics relates to conversations I've had with Dr. Breitschwerdt and that helped me understand the veterinary experience with antibiotics in their patients. The conventional protocols, particularly the one that's used the most, which is doxycycline and rifampin, doesn't seem to work well. It can temporarily improve things. The doxy part of it in particular seems to be relatively ineffective. Oral antibiotics, I think, are adequate. I do not think IV antibiotics are needed unless they truly cannot take anything by mouth if they're extremely sick. So I try very hard to avoid IV antibiotics. There are many reasons for that. One of the newer reasons is that we're now finding that there's biofilm on the catheter, and that biofilm contains, we've demonstrated Bartonella by immunostaining in the biofilm on the PICC line catheters. So I believe that IV antibiotics actually ultimately get in the way of successful treatment. There may be questions of intracellular or extracellular permeation by the antibiotic. These germs can move into the red cells, and so if you don't use an antibiotic that can penetrate the cells, they may temporarily move into the red cells to avoid it. Ideally, we'd like to use bactericidal antibiotics, but most of the ones we have available orally are not cidal, and therefore we're working with bacteriostatic antibiotics, again, pointing to the need for a longer course of treatment. We discussed cytochrome P450 induction or inhibition. That's very important to consider. And of course, we have to remember that rifampin and its cousin mycobutin can induce relative adrenal insufficiency by A, depleting hydrocortisone, and B, increasing the need for hydrocortisone at the same time. And finally, we have to keep in mind that there's a distinction between antibiotic resistance and antibiotic persistence. The persistence may be from the fact that the microbes are protected in biofilms and cysts. Next slide. So how do I approach the treatment? And specifically, because of the nature of the webinar, I was trying to be careful about not having patients and clinicians make mistakes. So I didn't want to be too specific here, but I wanted to give you a good idea as to how I approach it. I start with clarithromycin initially, and there are several reasons for that. One of those is that clarithromycin inhibits the same cytochrome that we've been talking about, the cytochrome P450-3A4, and therefore it raises hormone levels and actually makes patients feel a little bit better. There's some indirect evidence suggesting it may reduce endothelial proliferation, which we believe is not shared by azithromycin, and this is based on a paper from the Reservoir laboratory in France. And so I start with clarithromycin, and the question of quinolones comes up a lot because it is used commonly in the veterinary clinical world, and I just have a lot of concerns about them in humans because in addition to the known side effects of tendinitis and potentially tendon rupture, there is good evidence for the fact that the quinolones like ciprofloxacin, levofloxacin actually reduce and shorten the telomeres. Telomeres in cells determine the longevity of the cell. So I worry about causing a greater harm in the long term in humans who usually live considerably longer than, for example, dogs and cats. So I just tend to avoid those if at all possible. We discussed doxycycline. Doesn't seem to be too helpful, but sometimes it can be added, and sometimes it's a good way to begin. Then after a month of clarithromycin, I add rifampin. And in some patients, because of the cytochrome profile and the other drugs they may be on, I would then use rifabutin. It induces only cytochrome 3A4, whereas rifampin induces 4 or 5 different cytochromes. So in the first few weeks of clarithro, there's usually some gradual improvement. People feel like they're out of crisis. And then when we add the rifampin, within sometimes a couple of weeks of either the first dose level or doubling, there is usually a major increase in joint aches and pains. I don't think it's a classic Jarisch-Herxheimer reaction. It's usually not associated with high fevers, but I believe it's primarily an immune complex arthropathy and or collagen-associated inflammation. So after this flare-up occurs, and by the way, when this flare-up is occurring, patients usually have a little more energy, they're thinking a little more clearly, and they kind of come in a little happy that they're actually responding. But then they gradually improve with regard to the pain over 3 to 4 months. It's a gradual process, and I just reassure them and use some supportive modalities like anti-inflammatories, vitamin C, and just supportive care. I've had no cases of C. difficile, but that's because I use a double dose of a strong probiotic twice a day. If I give the antibiotics breakfast and dinner, I give the probiotics lunch and bedtime, away from the antibiotics. Next slide. In all the patients, and there have been hundreds of them, I've only had 9 lab-confirmed cases of persistence after approximately slightly over 6 months of double antibiotic therapy. And this is a pretty good success rate. I'm sure the numbers are higher, but it's sometimes after patients are well, and they're mostly well, they sometimes disappear because they're happy with where they are. So I think we have not done this long enough to know what the true success rates may be for this antibiotic regimen. And I think this is one of the most important areas of research because it's very hard to do sensitivity testing for this kind of microbe in vitro. And most germs, as we know, really change their biology considerably, activate and suppress various genes when in vivo. So we really need some good comparative efficacy studies clinically to find the optimal antibiotic protocol. And I think those studies should also include potentially some non-antibiotic treatments, potentially some natural approaches that might help. I don't have any good ones to suggest, but we should always be looking for ways of reducing antibiotic use if at all possible. So I think we all share that concern, but when you're taking care of sick patients, you just have to sometimes do what you need to do to get them better. And I constantly review things with the patients, insist on them taking it a certain way, trying to make sure they're compliant. Frankly, not everyone can do this, so compliance is sometimes a problem. Next slide. Next slide. So if there is a stereotypical clinical lab profile of a Bartonella patient, it would be mild liver function elevation before treatment at the time of presentation or diagnosis, which then can transiently increase during treatment. They may present with a slightly low white count, which in the differential would be a low-level neutropenia. Some patients were told they normally have low neutrophils, might in fact be the ones with Bartonella. There are known conditions associated with low neutrophils. We think it's a normal variant, but I would love to see a study of Bartonella in those patients so we can really prove that. I think that's a low research priority, but that question looms in my mind. The C4a is typically elevated. This is a breakdown product of complement factor 4, and it indicates complement activation by antibody and the initiation of the membrane attack complex, complement factors 5 through 9. So what I'll show you in a moment is that this is more elevated if the antibody levels are there, if IFAs are positive. The CRP is not very helpful. Next slide. So to summarize, the optimal enrichment culture for diagnosis would be to test 3 times over a period of 1 to 2 weeks, and this is to overcome the sampling error. We estimate that the sensitivity is approximately 90%, and it's really hard to gauge that when you have something that works a little bit better than what's been out there. How do you know, what's the new gold standard that you would compare it to? So we're always trying to optimize the PCR strategy and the culture medium to try to optimize and increase the sensitivity. The specificity is essentially 100% with the enrichment PCR, because the sequence is then the isolate is DNA sequenced to confirm. So if you get a hit, you can be pretty sure that it really is Bartonella. If the antibodies are negative and if the cultures are negative, I would suggest repeating it for another triple set, maybe a month later. And because the antibodies may well be negative, I don't think they're very helpful for initial diagnosis. However, I do think they're very helpful for monitoring, because if you're treating someone and you're not certain, you want to see if during treatment the serologies change, because then a month or 2 into it, you can have further confirmation, or even that may be your only confirmation if you're treating based on a high clinical suspicion. And so I think antibodies alone might be very helpful during treatment and potentially after, to see if there's a change. And then finally, I think this is a bit open-ended. We're trying to figure out the optimal, but at 1, 3, and 6 months after treatment, I would suggest would be the ideal time to reculture the individual to confirm that it's been fully treated. Next slide. Of note, when Bartonella is present in cats, it's at a considerably higher level, particularly in association with red cells, and the levels are quite a bit lower in humans and in dogs. So this is one of the reasons why fleas on cats may be more likely to transmit, just because the cat biologically just carries a higher level of Bartonella when bacteremic. Next slide. And as covered by Dr. Brycewart, you have a limited number of options to raise the threshold detection. You can improve the limit by culturing. You can change your sensitivity, or you can culture the bacteria up to levels that can be detected. Next slide. Again, this is a summary of the Bartonella ePCR. So from a single blood specimen, we PCR blood and serum, and then we culture, and then PCR that, and then compare that as a single draw to a triple draw. We're finding that the triple draw is about 9 to 10 times more sensitive, but that the single draw is 4 to 5 times more sensitive than just a single test, PCR alone. Next slide. So this is a summary of the lab markers in the patients that were published and described in Emerging Infectious Disease in 2012. This lab data was not published as part of the paper, but we're compiling actual clinical data for a second publication describing the other laboratory features of those patients. So what we can see in patients who, if you look at the second column, those that are IFA positive tend to have higher C4A levels. I will tell you right now that the error bars on these overlap a lot, so I don't think that the C4A is a way to differentiate adequately. But on average, they're higher. So one potentially could devise a lab meta-analysis or an algorithm that would look at a few factors to try to screen for high likelihood of Bartonella. The C-reactive protein was highest in those who were PCR positive, enrichment PCR positive, but who were IFA negative. And so it could be that the lack of the antibody is actually causing more inflammation because the immune system can't control it. The SED rates completely insensitive and totally useless, even though this is an endothelial endovascular infection, and with vasculitis certainly we do look at the SED rate. In this particular case, the SED rate is entirely useless. Some autoimmune conditions like sarcoidosis are associated with a very high 125 dihydroxy vitamin D. And in looking at the ratio of that to regular D3 can sometimes give you an idea of how much 1-alpha hydroxylase from macrophages is active. And so looking at that ratio, I find that they were slightly higher, but again, not significant, and I don't think it would be helpful. These numbers vary. I can tell you they vary a lot among the patients. And so I think when you look at the averages, it may not be too helpful, but I'm optimistic that we can create some sort of algorithm that can rely upon multiple markers to help guide us as to who to test. Next slide. So just to remind everyone, depending on who you read and quote, experts believe that translational medicine is a process that takes 17 to 21 years. And so that corresponds approximately to one generation of leadership. And that's why there's an expression that science progresses one generation at a time. So we kind of need a new guard to come in and say, hey, let's look at things a little bit differently. Now, we live in the world of information technology, and a great example is this webinar. So we have the potential, if we're tracking how patients are doing in real time, such as through a registry, to be able to know up to the minute how the treatments are working out among all the different individuals. And so we live, on the one hand, as clinicians in a world of high patient need, extreme suffering. There's a huge clinician burden to take care of folks with some of these chronic illnesses. And unless the policy support is there and the research support is there, these patients don't get reimbursed by insurance. The clinicians who take care of them get persecuted. And there are countries around the world where if you want to get antibiotics for more than 2 weeks, you literally have to leave the country to do that. And so this is a really an inhumane situation in many cases. So I hope that we can find better ways to accelerate this innovation cycle and to have open dialogue and even understand where in the translational medicine timeline a technology exists, so that we can have a scientific framework for understanding how science and medical science evolves rather than a political bureaucratic one. Next slide. So in summary, accurate co-infection testing clarifies complexity, it saves time. A lot of folks who have Lyme disease don't want to get Bartonella testing, and they're treated empirically, and I believe those treatments are not successful. The IFA antibody levels can surge during treatment, but they're often negative at baseline. The baseline positive rate in a Bartonella patient is somewhere around 20%, 20-30% maybe. And we definitely need comparative outcome studies of antibiotic combinations. We really just seem to have one protocol that, through our experience, seems to work, and I don't know, I have not had time to compare it to any other protocol. The true relapse rates are unknown, but they seem relatively low for now, and the overall treatment seems to be good, but it takes time, and it's difficult, and for many people it's very expensive and not tenable. We need a higher clinical awareness of small vessel disease for better screening, and I think that clinicians would do well to learn the subcortical neuro exam. And then finally, remember that the host response is highly variable, and so you can't look for a single feature or a set of features that define Bartonella. I've had patients constantly ask me, you know, what are the symptoms, because they think it's something that can be diagnosed clinically. I think I might be able to do it with a higher success rate, having seen so many cases, because you just develop a feel for it. And as I said, you know, patients will come in explaining many symptoms. I see those as pixels in a big picture that I've seen over and over again. So I don't want people to think that there is a single clinical presentation, but when you see a lot of different symptoms, you should think small vessel disease. And in these patients who may have a wide variety of symptoms that some people call a list of symptom patient, you should be thinking about endovascular inflammation and then the causes of that. Next slide. So my final slide is to quote former Surgeon General Everett Koop. And I got this quote from someone who was his right-hand man, Peter Hartsock, who was in charge, he and Dr. Koop together were in charge of the needle exchange program for HIV when it was launched in the early 90s. And so in response to the political pressure he was receiving to stop research and funding support for HIV, he was quoted as saying, "You don't play politics with people's lives." And I would leave you with that. I think we're in a similar scenario, and I would just ask that everyone proceed with compassion as we're trying to develop a new area of science. Next slide. So finally, in order to be able to get more data to inform hypotheses for further clinical trials, we're going to develop a registry that patients can sign up for, and they will be encouraged to enter their clinical data, their test results, and their treatments and their symptoms, so that we can gauge, measure, track the responses to treatment, and in the course of doing so, be able to greatly accelerate the translational medicine timeline for Bartonella care. That's it. I thank you for your attention, and I'll turn the presentation back over to the organizers.
Thank you, Bob, for the presentation. I believe we're right at 2, but if everyone has time to stay around for maybe 1 or 2 quick questions, that would be great. Amanda, are you able to read off some of the questions?
Yes, can you hear me okay?
Yes.
Okay, great. All right, so we'll field a few questions in the time we have available. Ed, a question for you came early on. Are stick-tight fleas echidnophaga or houseflies vectors?
Peter, can you hear me?
I can hear you, Ed.
You can hear me?
Yeah.
There have been, to my knowledge, no PCR studies looking at either stick-type fleas or houseflies, or to date mosquitoes.
Okay, thank you. And let's see. So this gets to where Bob ended his presentation. So Bob, I'm going to direct this question to you. If the science has shown Bartonellosis is a chronic bacteremia, why are medical guidelines still defining it as a self-limiting disease?
Well, you know, there's, without any criticism and really just to look at it as a no-fault approach, when there's something new, it simply takes time for everyone to become aware of it, learn it, and incorporate it in their process. And so I think it's never been more true than today, because there's so much information coming out there in medical science that it just takes a lot of time for the system, if you will, to try to adopt it. And in reimbursement models, they want to be extra certain before they're going to feel like they have to fund something. And so I think particularly in a cost-constrained medical environment, resource-constrained, cost-constrained environment, they tend to adopt more of a nihilistic approach. And so I think that the level of evidence that has to build up, we used to think that once it builds to a certain level, suddenly people will change the way they do things. What I'm finding is that it's a little bit different than that, people can always choose to be late adopters, and what we're going to do is try to get better data more quickly collected to be able to drive a judgment in almost real time within a few months of data collection as to what the optimal strategy would be. So there are various nice systems that governments, others have put in place to look at outbreaks of acute severe disease, but I think no one's really applied that yet to kind of the more gradual, time-expanded, slower progression and response to awareness and management of chronic disease. So we're doing what we can to change it, but you know, the person asked the question is entirely right. If you read a textbook of internal medicine, it'll say that Bartonella is a benign self-limiting infection that doesn't require and may only sometimes require 2 weeks of antibiotic therapy, perhaps with azithromycin. So that's the teaching from the old textbooks.
Right. Ed, would you like to add anything to that?
No, I think Bob did a good job covering it.
Okay, great. So the next question is for Ed. The paper referring to 1 to 6% advanced breast cancer, CA, non-hormone dependent, chemo-resistant, were CD57 cells monitored.
Repeat the question.
Regarding the paper referring to the 1 to 6% of advanced breast cancer, were CD57 cells monitored?
Our only involvement in that study was to look at effusions from 2 patients that had developed pleural effusions, were cultured, their cancer cells were cultured in vitro, and a full publication has never materialized, and therefore I've never seen that data, so I can't answer the question as whether that was tested or not.
Okay. All right, so Bob, this one's for you. Since this is an intravascular infection, have you received any reports of vascular pain in human cases?
Well, you know, pain means that you've activated some nerves. So I would say I wouldn't call it vascular pain, but people get painful neuropathies because the vasculature affects the nerve function. Not for this microbe, but there are other microbes that have been shown to directly induce pain in nerve fibers. But I'm pretty sure no one's looked at that for Bartonella.
Okay. Ed, I'm going to direct this next question to you. Could an IgM positive antibody test for Bartonella be false positive if it persists after antibiotic treatment?
As a veterinary internist who deals with quite a few different infectious diseases, I have always been very reluctant to make clinical decisions on the the sole basis of an IgM antibody, and my rationale for that is, on an evolutionary basis, it certainly appears that IgM is a very rapidly responding antibody. It's a very large antibody, but it is also one that we all know lacks specificity. So if I had a patient that was IgM positive and IgG negative and had symptoms, that I think my tendency would be to look for another disease.
Okay, great. So Bob, a question for you is, in your standard practice, what role does immunosuppression play in patient treatment?
It's a good question. I do often look at CD57 levels, and I do find that they're suppressed in Bartonella and not just Borrelia. So I think that it's low, but with any hypothesis, I really like to pressure test it and question whether or not a low CD57 actually implies immune suppression. Because if those cells go active and they're out in the tissues doing things, then the levels could go down in the circulation. So we're very limited in that we just can look at blood. I mean, we should ideally be able to, we would want to test those levels of natural killer cells and other cells in soft tissues and collagen, etc. So I would say that from a practical point of view, the immune suppression does not play a significant role. I will also add, and Ed may be able to expand on this, but Bartonella is known to secrete some immunosuppressive factors, and it also has some resemblances to Brucella, which is also known to induce a sort of immune energy. So I don't want to downplay the issue. I think it's significant, but it may be that as we treat these infections, the immune system then kind of comes back online, and some of the symptomology we see during treatment after the infection has been there a long time may in fact be from a hyperactive kind of a reversal of the immune suppression.
Okay, great. And then for Ed, what do you see in terms of antibiotic resistance with Bartonella or across species?
Well, I would start by saying there has not been nearly enough work on looking at antibiotic resistance in isolates coming out of patients. And part of the problem there is getting a stable subculture isolate, even after any form of enrichment culture, continues to be challenging. Both Didier Réaule's lab, or Jean-Marc Rollin's lab in Marseille, France, and our laboratory have looked at various resistance genes in the context of Bartonella henselae, and the way that is done is essentially by passaging the bacteria in the presence of the antibiotics. And so, one, you can induce resistance. Two, we can characterize what genes are involved. But I think three, we actually need molecular approaches to determine when we're able to amplify Bartonella DNA, whether we're also able to identify a resistance gene, because still the rate limiting factor for individual patients is our inability to obtain an isolate in probably greater than 90% of these patients.
Great, thank you. And last question, I'm going to direct to Bob. How can physicians learn to do a physical exam to diagnose small vessel disease associated with Bartonella?
Great question. I've done my best to try to teach this. I have found that when you bring this up and discuss it with neurologists, many of them will say, oh, aha, yeah, I kind of remember how to do that. But they don't routinely do it even on their own neuroexam. So I would approach a neurologist who you feel is good and and ask them to kind of work through that with you. They may need to brush up a little bit on it, and then kind of go over with you how to do that. I think it's a great question, and maybe one day we'll put a little webinar together on a neuroexam for small vessel disease. Great.
I'd like to thank everyone for attending today and for putting up with the technical difficulties. And I'd like to remind you that a link will be sent out to a recording of the webinar to everyone who's registered. And if you have any other questions, please feel free to contact Galaxy Diagnostics at contact@galaxydx.com or give us a call, and we'll try to get answers. Thank you so much.
Thank you, everyone.
Thank you, everyone.